Good evening, everyone, and thank you, AIOS, Dr. Biswas, and Somshila for organizing this interesting symposium on uveitis. In the coming 10 minutes, I would be speaking on the various COVID-related infectious uveitis lesions that we have all seen in our clinics. We all know that the ocular manifestations and COVID-19, basically the various manifestations have been secondary to either vascular, neuronal, inflammatory, or opportunistic infections. Now, out of all the manifestations which have been reported, I think the opportunistic infections have been the least reported in literature as of now. These can be triggered by the viral infection itself, and the mean age of presentation that has been reported is about 50 years of age. The median duration between the diagnosis of COVID and the ophthalmic symptoms has usually been 12 to 15 days, ranging between 4 to 55 days. So COVID-19 basically impacts the immune system of the patient and significantly decreases the CD4 counts. Now, we all know that corticosteroids is a life-saving drug in patients suffering from COVID-19, but it's like a double-edged sword. So it can further worsen the already compromised immune system of the patients suffering from COVID-19. Now, these are the various infectious uveitis lesions which have been reported, such as atypical ARN, retinitis lesions secondary to Candida and CMV, choroidal abscess, bacterial and fungal endogenous endophthalmitis. Now, this is a patient which has been reported with atypical ARN. And why it was atypical ARN? Because it had significant vitritis even in an immunosuppressed patient suffering from diffuse large B-cell lymphoma and on rituximab and chlorambucil. And what they have actually said is that probably the COVID-19, it breaks the blood-retinal barrier, and therefore the immune response can be increased in patients who are even immunosuppressed. So that's why it was like an atypical ARN presentation. Candida retinitis is something, another manifestation which has been reported, and this is a young 42-year-old diabetic hypertensive patient recovering from COVID-19 with a history of hospitalization and treated with tocilizumab and on ventilator for 3 weeks, and also given intravenous steroids. Typically, these patients presented with these multifocal retinitis lesions. And as you see, there's a very classical presentation of the vertical invasion of the Candida organism into the vitreous cavity, which is beautifully appreciated on the OCT images. Dr. Malika and Dr. Somshila, they have also reported very beautifully in their article the various manifestations of COVID-19, and they have also reported this 57-year-old male patient who was again recovering from COVID infection, having Candida septicemia and a renal infection, and had again multifocal retinitis lesions treated again beautifully with intravenous and intravitreal voriconazole with a very good recovery of vision. Tubercular choroidal abscess is another case which has been reported by them, and this particularly a patient who showed this yellowish lesion with a lot of satellite lesions. And to their surprise, also, they when treated this patient with ATD, it responded very well. And that is why they came to the diagnosis this probably was a tubercular abscess. There are also reports of reactivation of viral infections in patients suffering from COVID, and also having HIV positivity after 1 month of COVID infection. There is also reactivation of herpes simplex virus and CMV reactivation, which has been reported with manifestations as typical as a frosted branch meningitis. Now, coming to infective endophthalmitis, so this is an indirect manifestation of COVID-19. It's found usually in seriously ill patients who are admitted in ICU with diabetes, with long-term IV lines, high dose of steroids, uncontrolled blood sugar levels, and last but not the least, treated with immunosuppressants. As we know that the patients already have low CD4 and CD8 counts, there could be a hematogenous spread of microorganisms from endogenous foci of infection. They could typically present with signs of endophthalmitis, which we all are aware of. And there have been reports of both bacterial and a fungal etiology. So this was a case series where they reported 4 cases. All of them were culture negative. They had subretinal abscess in all their 4 patients. But they possibly could not prove that this was a fungal infection, but they assumed that it was a fungal endogenous endophthalmitis because all the patients, they responded very well to the antifungal treatment. This is one of the patients which I have seen in my clinic, a 44-year-old male diabetic patient, Again, you see presented with fulminant endogenous endophthalmitis signs with pain, redness in the left eye for last 10 days. He had suffered from COVID 2 months back with hospitalization and IV steroids history. The vision was as low as counting finger close to face. We went ahead and we did a vitrectomy for this patient, and the sample showed Candida albicans, which the species that grew on the microbiological examination. This patient again responded very well to voriconazole, and the vision recovered to about 6/9 N9. This is a patient which has been shared to me by Dr. Ale, who is there in the session today. A patient, 61-year-old male patient who presented with diminution of vision and redness and pain in both eyes 1 month back. And for last 1 month, patient had suffered from COVID-19 3 months back and was hospitalized and treated with remdesivir and IVMP. Again, the vision was extremely low in the left eye. You see there were fulminant exudates in the vitreous cavity. This patient was treated with voriconazole and amphotericin B, and it grew a fungal infection by the name of bipolaris species, which is again a very rare fungal infection that we often don't see in our clinics. This is another report by Dr. Darius and his group where they have misdiagnosed, all the patients were misdiagnosed as non-infectious uveitis and treated with steroids by the primary treating ophthalmologist, and they ultimately turned out to be fungal endogenous endophthalmitis secondary to Candida and Aspergillus infections. This is another young, unfortunate 35-year-old female who presented to me with bilateral visual loss. She again was admitted for COVID 2 months back, and she presented with panophthalmitis in both the eyes. The vision was as low as plus minus perception of light in the left eye with no perception in the right eye. And it was a desperate situation. So I did go ahead and I did core vitrectomy for this patient. What was surprising was that 2 months later, also she continued having high levels of CRP, and her D dimer were also raised. Her blood cultures and urine cultures were all negative, and we really didn't know what we were dealing with. And just a few days back, we got the report that it was actually a Klebsiella pneumoniae infection. And if you see the sensitivity report, it was apparently resistant to most of the antibiotics that we had actually used while treating this patient. Coming to bacterial endogenous endophthalmitis, there are a few reports again in the literature. What is interesting is by this Italian group who have reported 4 patients, they have identified Klebsiella pneumoniae in one of the patients, which was again multi-drug resistant like our case, but they also detected the COVID-19 virus in the virus sample, but they were not sure if the endophthalmitis was secondary to the viral infection or it was because of the Klebsiella, which they also cultured in the urine and the blood culture samples of the patient. So I would just conclude my talk by saying that COVID-19 patients, they are immunosuppressed due to concomitant diseases like diabetes, use of high dose of steroids or immunosuppressants, leading to reactivation of latent infections or opportunistic infections, or a hematogenous spread of endogenous foci of infection to the eye. Ventilators, intravenous lines, or bottles of oxygen cylinders are potential sources of infections in these patients. These infectious uveitis implications have been a direct or an indirect implication of COVID-19 infection in these patients, and we all need to be aware of it and treat them, and not treat them as non-infectious uveitis, thereby treating with more and more of steroids and immunosuppressants. And I just want to highlight that recently we also issued on behalf of Uveitis Society of India an advisory to all the ophthalmologists who have been actually diagnosing these patients as non-infectious uveitis and treating them with steroids, which have actually led to the situation becoming worse in these patients. So this is something we all need to be aware of, that there is a lot of reactivation and opportunistic infections in these immunosuppressed patients that we are dealing in today's time in our clinics. Thank you.